Somewhere in this country, right now, someone is standing in their bathroom, looking at a row of orange bottles they've taken for years, a sleep aid, something for the bladder, maybe a pill for heartburn that's been part of the morning routine for a decade. None of them look dangerous. All of them were prescribed or picked up over the counter by people trying to feel better. Here's the thing almost nobody tells you. A surprising number of common medications interact with a single brain chemical called acetylcholine, the messenger your brain relies on to form new memories and stay sharp. And the effect of blocking that chemical doesn't always show up as a warning label. Sometimes it shows up as getting older. This isn't a story about one villain drug. It's about a pattern that researchers have been documenting for over a decade, published in places like JAMA Internal Medicine and the BMJ involving millions of patients. Let's walk through what the science actually says, drug class by drug class, and what you can realistically do about it. The chemical at the center of this acetylcholine is a neurotransmitter, a chemical messenger that your brain uses constantly, especially in a region called the hippocampus, where short-term memories get converted into long-term ones. As people age, the brain naturally produces less acetylcholine and becomes more dependent on what's left. Any drug that blocks acetylcholine receptors is called an anticholinergic. Some drugs are anticholinergic by design, that's literally their job. Others block acetylcholine as a side effect of doing something else entirely, like calming an overactive bladder or easing depression. The problem is that very few of these drugs are marketed with affects memory anywhere on the label, so the connection rarely gets made until real cognitive ground has been lost. Researchers have built scoring systems, like the Anticholinergic Cognitive Burden Scale, specifically because doctors and pharmacists were finding it too easy to miss how many anticholinergic drugs a single patient was stacking at once. The everyday antihistamine. Start with something almost everyone has touched. Diphenhydramine, sold under the brand name Benadryl and found inside most PM or nighttime sleep formulas. It's cheap, it's unregulated, and because no prescription is required, people assume it's mild. Pharmacologically, it's actually one of the stronger anticholinergics on the market, strong enough that geriatric guidelines specifically flag it as a drug to avoid in long-term use for older adults. A large body of research, including the landmark 2015 JAMA Internal Medicine cohort study led by Shelley Gray, followed thousands of older adults and found that cumulative use of strong anticholinergics, a category that includes diphenhydramine, was associated with a meaningfully higher risk of developing dementia, with the risk climbing as the cumulative dose climbed. It wasn't a one-time exposure that mattered, it was years of nightly use adding up. If you or someone you're caring for reaches for a PM pill out of habit, that's worth a conversation with a doctor or pharmacist. Newer generation antihistamines like loratadine cross into the brain far less and are generally considered safer for regular, long-term use. The heartburn pill nobody wants to stop taking. Proton pump inhibitors, omeprazole and esomeprazole are the household names, are enormously effective at shutting off stomach acid and enormously easy to stay on indefinitely because symptoms often rebound the moment you stop. Millions of people have been on them for years without ever revisiting whether they still need the full dose. The connection to cognition here runs through nutrition, not a direct chemical block. Stomach acid helps the body absorb vitamin B12 along with magnesium and calcium, nutrients the nervous system depends on. Long-term acid suppression can quietly erode B12 levels over years, and B12 deficiency in older adults can produce confusion and memory problems that look strikingly similar to early dementia, simply because the two conditions overlap in symptoms. Several observational studies have also raised the question of whether long-term PPI use is independently associated with dementia risk, though the evidence here is more mixed than for the anticholinergic drugs. Some large studies have found an association, others haven't replicated it. It's an active area of research rather than settled science, which is exactly why it's worth periodically asking a doctor, do I still need this at this dose indefinitely, or could I step down to a lower dose, an H2 blocker like famotidine, or lifestyle changes? Medications for the bladder. Overactive bladder medications like oxybutynin work by blocking acetylcholine directly in the muscles of the bladder, but the drug doesn't stay conveniently confined there. It crosses into the brain quite readily, which places it among the more concerning anticholinergics for long-term use in older adults. Multiple studies, including work published in the BMJ, have found associations between long-term use of strong anticholinergic bladder medications and increased dementia risk in adults over 65. The reassuring part: newer options like mirabegron treat the same symptoms through a completely different pathway that doesn't touch acetylcholine at all, and many patients get comparable relief. It's a genuinely useful thing to raise at a follow-up appointment if bladder control and memory both feel like they're on the table. Older antidepressants built before anyone knew better. Amitriptyline and similar older generation antidepressants, sometimes still prescribed for nerve pain, migraines, or sleep because they're inexpensive and versatile, are among the most strongly anticholinergic drugs still in circulation. Because they're often prescribed for something other than depression, patients frequently don't think of themselves as being on a psychiatric medication at all, which means the anticholinergic conversation rarely comes up. The 2015 Gray et al. Cohort study specifically identified this class among the strong anticholinergics tied to elevated dementia risk with sustained use. Newer options exist for essentially every reason amitriptyline gets prescribed: duloxetine or gabapentin for nerve pain, low-dose doxepin or melatonin for sleep, and SSRI is like sertraline for mood, all with a much lighter anticholinergic footprint. Not every antidepressant is equal. Here's a detail that surprises people. Within the SSRI family, generally considered the gentler, more modern class of antidepressants, paroxetine stands out as the one with meaningfully more anticholinergic activity than its siblings like sertraline or escitalopram. That single pharmacological quirk is why some prescribing guidelines for older adults flag paroxetine specifically as one to use cautiously or avoid in favor of alternatives in the same drug class that don't carry the same burden. This is a useful reminder that same category of drug doesn't mean same risk profile. The differences between individual medications within a class can matter more than the class label itself. Drugs meant for serious psychiatric illness used for something else. Antipsychotics, quetiapine, risperidone, olanzapine, were developed and approved for conditions like schizophrenia and bipolar disorder. In practice, they're also prescribed off-label fairly often to older adults for agitation, restlessness, or sleep, particularly in care facility settings. This is a genuinely contested area in geriatric medicine. Multiple studies have raised concerns about accelerated cognitive decline, increased stroke risk, and increased mortality when these drugs are used this way in older adults, which is part of why several medical bodies now recommend they be reserved for cases where non-drug approaches, routine, reduced overstimulation, treating underlying pain, have been tried first. If a loved one has been started on one of these medications for behavioral symptoms rather than a primary psychiatric diagnosis, it's entirely reasonable to ask the prescribing doctor directly what the goal is, how long it's meant to be used, and whether non-drug approaches were considered first. Sedatives for anxiety and sleep, benzodiazepines, lorazepam, diazepam, alprazolam, work by boosting a different calming brain chemical, GABA, not by blocking acetylcholine directly, but long-term use has its own well-documented relationship with cognitive decline in older adults, and several large longitudinal studies have found higher rates of dementia diagnosis among long-term users compared to non-users, particularly with the longer-acting drugs that build up in the body over time. The critical safety point here is different from the other drugs on this list. Benzodiazepines should never be stopped abruptly after regular use, because withdrawal can be genuinely dangerous, including a risk of seizures. Any change here has to happen gradually, under medical supervision. Alternatives like buspirone or structured therapy approaches for insomnia and anxiety can reduce reliance on these drugs over time without the withdrawal risk of stopping cold. Where statins fit and where the evidence gets murkier, statins get raised in this conversation more than almost any other drug class, largely because cholesterol is a building block for the brain's insulating tissue, and it's biologically plausible that aggressively lowering it could affect cognition. In practice, the research is genuinely mixed. Some observational studies have reported cognitive complaints among statin users, while some of the largest reviews and clinical trials have found no consistent evidence of cognitive harm, and a few have even suggested statins might be protective against dementia by reducing vascular damage in the brain. This is a good example of where the honest answer is, it's debated, not it's settled. If you're on a statin and you've noticed new fogginess, it's worth mentioning to your doctor. But statins are also protecting against stroke and heart attack, so this isn't a decision to make unilaterally based on one video or one article. The pattern underneath all of it. Individually, many of these drugs carry a small risk. The real concern researchers keep circling back to is what happens when several anticholinergic drugs are taken at once. A nightly antihistamine, a bladder medication, an old antidepressant for nerve pain, none flagged individually as dangerous, but stacking into a cumulative burden, nobody added up. Large studies using anticholinergic burden scales have consistently found that risk increases with the total cumulative dose across all anticholinergic drugs combined, not just any single one. The genuinely hopeful finding in this research, when anticholinergic burden is identified and reduced early, some of the cognitive effects appear to be at least partly reversible. That's very different from irreversible neurodegenerative disease, and it's the reason this is worth taking seriously rather than dismissing as just getting older. What to actually do with this? None of this is a reason to panic or to stop any medication on your own. Some of these withdrawal risks are serious, and the underlying conditions being treated are real. What it is a reason to ask for what's sometimes called a medication review. Sit down with a doctor or pharmacist, bring every prescription, every over-the-counter pill, and every supplement, and ask them to look specifically at the combined anticholinergic load. It's a 15-minute conversation that, for some people, changes everything. If this was useful, the most important thing you can do with it isn't to trust it blindly, it's to bring the question to the person who actually knows your full medical history.